Now let's move on to the local occlusal road. What we will look at so far is about the general occlusal road that will be acting in common and even of all teeth in the mouth. However, the occlusal road that will be acting over specific tooth is variable because it depends on situation and surrounding environment of it. So I think we need to consider the conditions of occluding teeth and adjacent and collateral side teeth because there may be an additional occlusal road at each fixture to be planted respectively. For this reason, it's called the local occlusal road, and I think we need to consider not only the general occlusal road but also the local occlusal road in order to evaluate the required fixation force. First, let's think about occlusion of occluding and adjacent teeth. If we perform an implant at the 46 molar of patient with this good occlusion, 46 implant would be under considerable amount of occlusal road because it's in a good engagement with occluding 16-15 teeth. However, all the other adjacent teeth are occluding well and doing their part. So, the occlusal load is distributed evenly in entire dentition, and consequently, it will be under reasonable amount of occlusal load. Therefore, there is not additional local occlusal load to be considered. On the other hand, if we perform an implant at the 46 molar patient with this bad occlusion, we will be in bad engagement with occluding 16-15 teeth and all the other adjacent teeth are not occluding well either. So, the occlusal force that will be acting at 46 implant to be planted may be smaller than the occlusal force acting at this case with good occlusion. However, in terms of occlusal load, it may be concentrated at 46 implant because adjacent teeth are not there doing their part and especially 44 premolar is out of occlusion. Therefore, there might be an additional local occlusal to be considered. So, for these reasons, we need to consider occlusion of occluding and adjacent teeth. Now, let's think about the fixation force of occluding teeth. If we perform an implant bridge between the 46 and 44 fixtures and occluding teeth are natural teeth, usually it's not appropriate to perform an implant bridge. It's because 45 premolar is missing and 46 implant would be under extra occlusal load from the 14 teeth. And moreover, occluding 16 natural molar, which has the well-developed 3 roots, has a stronger fixation force than the 46 implant. So 46 implant will be under strong occlusal force from the occluding 16 molar. For these reasons, there will be additional local occlusal load at the 46 implant if we perform an implant bridge. So we need to consider not only occlusion, but also the fixation force of occluding teeth. So at this moment, looking at fixation force of occluding teeth, it's a proper time to talk about an issue, whether it's the right manner or not, to plan the single fixture for replacing the molar. However, the overall flow of context can be interrupted, so I'll postpone it to the end of this lecture. Anyway, if the occluding teeth are partial denture or bridge, it's a different situation from the previous one because the fixation force of occluding dent or breach is not that strong. So in a similar context, there is not additional local occlusion load to be considered. It's okay for the implant breach under these conditions. Let me show you cases as an example. It's a case of 6-unit implant breach and 3-unit breach performed at the same time bilaterally. Although the general occlusion load seems to be big, I guessed there was not big difference between the required and available fixation force. It's because that the occluding low tissue breach replacing the premolar and the other premolar was out of occlusion. So there would not be additional local occlusion load to be considered, and I thought it was not bad to perform an implant breach. However, if there was not patient economic problems, it was better to plan the pictures according to the number of missing teeth because general occlusion load was big. According to the same context, I either performed 3-unit implant breach because the occluding premolar was out of occlusion and the fixation force of the occluding molars was weak due to periapical region and endodontic problems. Here is another case. Let's apply all factors regarding general and local occlusion load. I guessed the general occlusion load of this paste was big, considering the periods and the root development and fractured 37 molar and the conditions of other remaining teeth. However, I thought the difference between the available and required fixation force of picture was not that much as seen because I guessed the local occlusion load was rather small. There were 2 reasons I thought so. Besides, they were in good occlusion bilaterally entire dentition. First, the fixation force of occluding teeth were weak because they were long breaches. Second, the size of occlusal tables was smaller than the normal size of that of molar. So, for this 46 and 36 implant would be under less occlusal load than the average. So, the remaining things to do were proper selection of picture after considering the level of gingival immunity and planting in the right manner and following the proper procedure. I'll talk about them later continuously in my lecture series. This time, let's think about the fixation force of adjacent teeth. We've already seen 46 implants to be planted, maybe under additional occlusal occlusion load due to the bad occlusion. When you additionally check out the fixation force of adjacent 47 molar in a panoramic view, the fixation force of 47 molar is weak because it's undergoing periodontal disease. So sometimes 47 molar cannot do its part. Moreover, the occluding teeth are natural teeth. So after considering these factors, it becomes clear the 46 implant to be planted would be under additional local occlusion load definitely. For these reasons, I think we need to consider the fixation force of adjacent teeth also. Finally, let's think about the case. The teeth on the contralateral or opposite side are under the same situation as we've seen so far. In other words, if we perform an implant on the side opposite to this side, the patient is willing to chew mainly on the side where the implant is performed because it's easier to chew, which is called unilateral side mastication. So, the implant to be planted on a side opposite to this side might be under additional local occlusion load. Therefore, we need to consider the fixation force and occlusion of teeth on the contralateral side. Let me show you several cases as an example. I guess that there's not general occlusion load to be considered. However, considering the situation on the contralateral side, one molar is missing and the other molars are severely decayed and occlusion is collapsed. So, the 36 and 37 implant to be planted would be under additional local occlusion load until the time the occlusion of contralateral side is restored. Moreover, considering that the remaining bone quantity is poor, this case is a complicated one. I'll talk about a case similar to this case at the end of this lecture. I guess the general occlusion load of this paste is big, and also there will be additional local occlusion load at the 35, 36, 36 implant to be planted. It's because that even though the fixation force of occlusive is weak and the size of occlusal tables is small, however, on the contralateral side, 47 molar is at the terminal stage of periodontal disease and 14 premolar is broken. So, it's better not to skip the picture and also try to get the fixation force as much as possible. I guess that the general occlusion of this patient is big after considering related factors. Moreover, there will be additional local occlusion load at the 36 implant to be planted. It's because that on the contralateral side, 17 molar is missing and 46 molar has apical region and also adjacent old implant is ready to fall out. In addition, even the residual bone width is narrow. Therefore, I think this case is complicated one because the amount of difference between required and available fixation force is big. I guess the general occlusion load of this patient is big after considering the related factors, especially patient disposition. Moreover, there might be an additional local occlusion load at the multiple fixtures to be planted after considering the situation of contralateral side. So it's a good decision to perform an implant on both sides at the same time. However, if it's impossible due to the patient's circumstances, I'd rather recommend you not to skip the number of fixtures. In other words, it's better to plan the fixtures according to the number of missing teeth. Who knows whether you can perform an implant on the contralateral side continuously or not. Finally, summarizing about local occlusion load, it's the same as the general occlusion load. If the local occlusion load is big, the required fixation force is bigger than the normal. After considering in addition that the available fixation force of implant is usually smaller than the fixation force of original natural teeth, there would be considerable amount of difference between the required and available fixation force. Therefore, we need to try to compensate for the lack of fixation force by these factors.